Early age onset cancers present distinct complexities, including more aggressive tumor biology, higher recurrence rates, and long-term treatment-related morbidity. For this subpopulation, personalized approaches that minimize toxicity and optimize efficacy are essential. Comprehensive genomic profiling, or CGP, is a key advancement in precision oncology, enabling genomic characterization of tumors to identify actionable mutations and guide those targeted therapy decisions. Despite its potential, access to CGP remains limited across Canadian health systems. As oncology moves away from a one-size-fits-all treatment approach, integrating CGP into standard diagnostic pathways offers a critical opportunity to improve outcomes, especially for younger adults with cancer. This discussion is on improving access to advanced diagnostics, and we're talking about comprehensive genomic profiling as a gateway to personalized treatment of metastatic cancer. A warm welcome to our panel moderator and valued steering committee member, Dr. Jason Karamchandani, President of the Canadian Association of Pathologists. We welcome Cynthia Mitchell, a cholangiocarcinoma patient and advocate, Eddie Nason, a Director of Health at the Conference Board of Canada, with whom CRAN worked collaboratively with to produce a first-of-its-kind CGP cost and benefit analysis, released just a couple of weeks ago. Dr. Robert Grant, medical oncologist at the Princess Margaret Cancer Centre, Dr. Megan Mahoney, Director of Scientific Affairs and Training at Biocan RX, and Dr. Alan Spatz, Chief of the Department of Clinical Laboratory Medicine at MUHC and Medical Director at the Optilab in Montreal. So warm welcome to our panelists, and over to you, Dr. Karamchandani.
Thank you, Cassandra. Good afternoon, everyone, and good morning to those of you joining from the West Coast. I'd like to thank CRAN very much for organizing today's symposium on advancing our access to comprehensive genetic testing and advanced diagnostics. We're going to cover several points during today's discussion. The first is how improving access to advanced diagnostics and comprehensive genetic profiling can improve diagnostic accuracy and empower patient access to precision therapies. We'll then move on to addressing some of the institutional and systemic barriers that may limit equitable access to advanced diagnostics. We'll then shift gears a little bit and talk about some of the economic benefits from comprehensive genetic profiling, and we'll conclude today's discussion around the concept around expanding equitable access to advanced testing and comprehensive genetic profiling. I was hoping to begin today's discussion by inviting our patient partner and patient advocate, Cynthia Mitchell, to describe a little bit about her own journey through the healthcare system and perhaps some of the issues around her access to both comprehensive molecular testing and access to personalized treatments. Cynthia.
Hi, good afternoon, everyone, and thank you to CRAN for inviting me to join this discussion today. In 2021, at the age of 41, I received a devastating diagnosis of bile duct cancer, and faced with limited and often ineffective treatment options, I did feel pretty overwhelmed by the constraints of both time and hope. However, through connections with international patient advocacy groups and healthcare providers at the time that were outside of Manitoba, I did discover CGP, comprehensive genomic profiling, and its potential role in treating bile duct cancer. What I never anticipated was the pivotal role that self-advocacy would also play in my care along the way. At the first sign of metastatic disease, I did request CGP, which thankfully Cancer Care Manitoba did fund. The results took months to get back to us, but ultimately revealed a highly targetable NTRK1 fusion, which set the stage for our next challenge, which was how would we get this drug funded? Thankfully, the pharmaceutical company did provide compassionate access to a drug called larotrectinib. However, when that treatment failed, we were forced to pivot to a second therapy, entrectinib. Cancer Care Manitoba at this point really took the reins, and I had to do nothing this time around, which was great. And they did secure funding to that drug through a provincial program. After a few months, it became evident that I wasn't responding to this drug as everyone had hoped. But with the guidance of experts in higher volume centers in both Toronto and outside of Canada, we did retest my original sample and conducted new testing on both tissue and liquid biopsies. And through these tests, we discovered an ERRFI1 gene mutation, which pointed to a drug in lung cancer that was quite effective and that I might also respond to. What followed was months of advocacy and persistent efforts. I faced numerous rejections, but with the involvement of my local team, these outside experts, patient advocacy groups, and a lot of work on my end, we did finally secure access through another compassionate program. And remarkably, I did experience a near complete response to with this treatment, followed by 18 months of stability. And in the bile duct cancer space, that's virtually unheard of. And so that was quite a gift. Fast forward to April of 2025, where extensive progression of my disease prompted more testing. And while we waited for the results of whole genome sequencing this time, we did do another liquid biopsy. And to our surprise, both of those tests revealed that the ERRFI1 gene mutation persisted, but that there had been a frame shift, which would necessitate a new targeted therapy called lapatinib. That was once again approved for another cancer, but not bile duct cancer. So again, I found myself advocating to access this treatment. I created videos for social media, sent countless emails, and made connections with people across Canada to see who could help. Eventually, I was approved for funded access through a compassionate program once again. So today we wait, but we have this sense of security, and because we know that should we have to pivot again, which we likely will, we have CGP, and it will play an important role. I think it's safe to say that CGP testing and the related therapeutics have been instrumental in extending my life from a mere 6 to 12 months to more than 4 years now. So this journey has come at a significant cost to my family, although I am grateful for the ability to have afforded testing as well as frequent travel outside of Manitoba. The financial burden is substantial. So we're looking at tens of thousands of dollars for testing alone, as 4 of those 6 tests were not funded. Further, of the 7 drug therapies that I've been on, 4 have not been approved for my cancer. So advocating for access to those therapies has at times felt unjust and exceptionally frustrating. The stress of continuously advocating for timely, effective, and equitable care is immense. I do like to say that I'm rebelliously hopeful, and I owe much of that rebellious hope to CGP. It has not only changed the course of my treatment, but it has empowered me as a patient and an advocate, highlighting the importance of patient engagement and care, as well as it's a great reminder to all of us of the importance of knowledge exchange, collaboration, precision medicine, and taking reasonable risks when challenging the status quo and seeking change. Thank you.
Cynthia, thank you very kindly for sharing your story. And I'm very happy to hear about the fantastic response you've had to these iterative precision therapies. And we wish you nothing more than continued good health. Thank you for sharing your experience. Dr. Grant, you run a comprehensive research program focused on hepatobiliary pathologies. And I'd like to hear about your perspective on access to CGP, particularly given the increasing rate of these precision therapies. And as an example, treatments focused on genes like KRAS, which are heavily implicated in these kinds of tumors.
Yeah, thank you. And thank you, Cynthia, for sharing your story, and to CCRAN for organizing this really important topic. So I'm a medical oncologist. I treat pancreas and biliary cancers primarily in Toronto. And So this has been a big change for us. a decade ago, the options were really limited to chemotherapy for these cancers. And biliary cancer, you've heard Cynthia's story, but this is an increasingly common story. Right now, at least a quarter of biliary cancers have targetable alterations, and FDA and sometimes Health Canada approved treatments that really depend on CGP to identify that marker and then to get that targeted therapy. So now this is something that's been revolutionary and transformative. They aren't yet, there's still work to be done. I think Cynthia's story explains that. We want longer, more durable responses, but to see these responses that we never saw before with chemotherapy has really been something to watch over the past 5 years. And the comprehensive piece is important. Targets that we know now didn't exist a year ago or 2 years ago. And I think the ERP1 is a good example. This is, I think, a target that many of us who are specialized in biliary cancer are just starting to recognize maybe an upcoming target for this rare cancer type. So this is a rapidly changing field, which is why this comprehensive profiling is so important. Pancreas cancer is another example. You alluded to KRAS treatment. We've known now for maybe 5 to 10 years that there's an important subset of pancreas cancers that have highly actionable alterations. This is enriched for young people, the topic of today's conversation. These are things, some of them are both inherited and alterations that we find in the tumor. So syndromes like Lynch syndrome, where the mismatch repair genes, this is the maybe 1 in 200 pancreas cancers that can respond extraordinarily well to immune therapy, right? And so in BRCA1, BRCA2, Angelina Jolie has popularized this syndrome. It's an inherited syndrome, but can also be found just in the tumor. And that this is something that can lead to exceptional chemotherapy responses, but also to some targeted therapy. So we've been learning more and more in pancreas cancer, but there's also, again, this concept of things changing. There's a gene called KRAS that's mutated in most pancreas cancers. And all of a sudden, they're not yet available in the clinic. They're still within clinical trials, but there's some really promising drugs just on the near-term horizon. And so I think I'm a strong advocate of trying to get all of this comprehensive profiling as early in the journey as possible. Cynthia's story raises some really interesting ideas, like this serial profiling. And we kind of struggle to get that first test, but we know these tumors evolve. And I think these are looking forward. This sort of serial profiling might be increasingly powerful because these adapt. We know BRCA1 and 2, you can revert the mutation back, and we can understand why resistance develops and maybe overcome it. So, and this is a rapidly changing field, but I think as a kind of foundation for everybody, many international guidelines, particularly for biliary cancer, but really for all advanced cancers, recommend CGP. And so I think that this is something we should be thinking about. From a clinical trial perspective, many of our clinical trials are focused on precision therapies, right? And so if you're open philosophically to the idea of clinical trials, CGP is often a core aspect of that. And then moving more into the research space, and what CGP often is, and Jason would be the best to talk about this, but it's focusing on the highest yield region of the genome, where we know the targets exist, where the cancer drivers exist, but there's a lot more to learn. And so putting a research hat on, we try to sequence the entire genome and the transcriptome, the RNA, and I think we're learning more and more about the importance of this broad perspective. And this is how we'll push precision therapy, and CGP may become more and more comprehensive as time goes on, and we learn how to use more of the genome, better treatments. Thank you.
Thank you, Dr. Grant, and thank you for your excellent work in patient care. To follow on that, I would like to invite Dr. Mahoney to not only talk about her perspective on the importance of comprehensive genetic profiling, but even the possibility of where in the period of care that this is accessed, meaning maybe earlier comprehensive genetic profiling would have advantages over later testing. So Dr. Mahoney, I'd love to hear your thoughts.
Thank you. And I think Rob set me up very well. So I would just echo that this is something that is part and parcel. So comprehensive genetic profiling is something that is absolutely necessary for the development of cancer immunotherapy drugs, which are under the umbrella of precision medicine in most cases. So I think that it comes on very early, and I'll address this in two different facets or different ways of thinking about it. So number one, when you get that diagnosis or you get news about your diagnosis, thinking about the clinical trial early and thinking about what that looks like in terms of the advocacy that you have regarding potential entry into a clinical trial is that first point that I would mention, and perhaps turn to Cynthia for any experiences she has on that, or the others. But the second is for researchers who are thinking about their product and the advancements and thinking about what this means from an equitable point of view, and do these mutations or is the CGP that you're thinking about affecting a broad population, and if not, what are the limitations to what you're developing? And so I would say that is the second consideration. There are some mutations that are more common in different populations, and so just having that sort of framework in mind that you're thinking about that as you're developing out your technology. I'd leave it there.
Thank you. You alluded this a little bit, but I'm curious about your perspective about the role of advanced diagnostics and comprehensive genetic profiling, specifically with regards to patient care and the age of the immunotherapy.
So, and I'd be speaking on behalf, so I really would turn perhaps to some of the experts on the call. What I've heard, so I'll say I'm a research administrator for an organization that funds cancer immunotherapy across the spectrum, both adult and also some pediatric groups that are doing this work. So by learning from them, I have heard that, pediatric patients and young adults they're not just little people, right? They have their own genetic profile, and the therapies that work for adults may not simply transfer over to children. So that is learning that we think about. That's something that we certainly would consider in terms of the funding and the programs that we offer. But I'll leave it there. Again, I'm not an expert on the techniques and the technologies. So Jason, I'll pass it over to you. That somewhat answers the question. I see Rob is unmuting.
Dr. Grant?
Yeah, happy to speak. So the immune system is very complex, right? A lot of the targets we're talking about are within the cancer cells, and we're directly testing there. And what we're asking here is about the immune system. There are some biomarkers like PD-L1, many cancers you'll test for, but the CGP can uncover immune sensitivities too. So one I'd mentioned before, that sliver of pancreas and bile duct, but really all cancers. There's a small proportion caused by Lynch syndrome or mismatch repair. And these are cancers that can have remarkable responses to immune therapies in ways that we wouldn't expect for the cancers I treat. And then there's another proportion of cancers that have what's called an elevated tumor mutational burden. So it sounds bad, there's lots of mutations, but for immune therapy, it's actually good, because the cells are so different from your body that the immune system just needs that extra nudge, and you can see these otherwise unexpected responses. So there's a lot to learn here, but CGP can identify these established biomarkers for immune therapy. And I know most about my own cancers where it's a small proportion, but my understanding is that this is the case really across the majority of cancers where there's a small fraction with high TMB or microsatellite instability.
Thank you, Dr. Mahoney. Thank you, Dr. Grant. We're going to shift focus here and talk about some of the institutional and systems levels issues that relate to this. And here I'd like to invite my colleague and chef de département, Dr. Spatz. Dr. Spatz, I'm a practicing pathologist, and I've seen the landscape of access to genetic testing completely transformed over the last half decade. And you've been instrumental in implementing these changes in the province of Quebec. I was hoping you'd be able to share with us some of your thoughts and experiences about how Quebec chose to implement access to these advanced genetic tests, and what you thought some of the successes and failures of that implementation were.
Thank you very much. Thank you, Jason, and thank you for this invitation. I just want to first state that it's extremely important that we better connect with patients' organizations across the country, such as the CCRAN. I do believe that if there is something we really need to improve collectively is the engagement of the population and the users in this extremely exciting shift to precision oncology connected with immuno-oncology and AI. Okay, so here I'd like to articulate two functions I proudly serve. The first is as president of the Quebec Molecular Diagnostic Network, which is a ministry, now Santé Québec, led network to implement molecular genetics across the province. And second is as chief of a department having to manage extremely important and daily operational considerations and financial considerations. So the first is that I probably want to state that a comprehensive genomic profiling is accessible and reimbursed in Quebec. It has been initially to the pediatric population through the connection of exome and genome sequencing, giving a full profile of what happens at the gene level, then extended to a very important population that we all very often forget. It's the adults, young adults and adolescent population, and then to older population in specific indications like the cholangiocarcinoma we have discussed, and low prevalence, meaning rarer situations. But now it's time to go beyond that, and as it was alluded to give a full picture of immune sensitivity of the tumor, looking at broadly the MSI, for instance, surrogates. So we know whether, for instance, there have been new antigens that have been engineered by the tumor cells that we can actionate through the immuno-oncology. And more importantly, maybe to give a full picture of what we call the HRD, which allows to give very effective treatments that will leverage on kind of weaknesses displayed by the tumor cells. So what I'm saying here is that there is a very important role for CGP. CGP is reimbursed in Quebec. It is accessible for the whole population, though we need at the same time to have a very careful assessment of the benefit cost and benefit operation aspects ratio. And to me, it would be completely futile to have a CGP, an all CGP approach, when we, for instance, very effectively can use more narrow tests that are more agile and that will allow, for instance, to sign out a report in 3 days instead of 15 days when it's necessary. So we need to very carefully balance the benefits and the operation aspects of CGP, and we have to do that together. So in brief, in Quebec, I'm very proud that we have been able to give access to CGP, and at the same time, we constantly need, as doctors and as health providers, to balance the benefits with operations. I just want also to say that it's important, and it has not been discussed yet, to say that CGP generates a considerable amount of data, and we need to store this data. We need to develop procedures across the country to access and exchange this data. And this is not done yet. So we are at probably the end of the middle age of this data management, and there is an urgency to move ahead fast and to move ahead collectively. And this, in my view, represents the main challenge and at the same time the main opportunity in the new AI era for the exploitation of this data.
Thank you, Dr. Spatz. And you actually addressed what I was going to ask you a little bit about, which is how you make decisions at the systems level about balancing the demand for CGP versus the benefits. And thank you for sharing that. Dr. Grant, I'd like to follow up with you, since a lot of the comprehensive genetic testing that you described is done in your laboratory setting. How do you perceive that from a sustainability perspective, and what would you like to see moving forward from the healthcare system?
Yeah, great question. Thank you, Jason. And I agree that this is something that should be universally accessible. It's in the guidelines, and I think the benefits for many cancers are clear, and biliary cancer is a clear example of that. We have a kind of dual mandate. Our grants and our donors are often looking for us to advance the science, and meaning in 5 to 10 years we have fundamentally better outcomes than we have now. On the other hand, the research depends on people contributing, patients, their time, the biopsies, biospecimens, and this is a really incredible kind of gift to the future, gift to future patients. But our philosophy is we'd like to be able to provide something back immediately as well, right? And this is why this comprehensive genomic profiling that we do, it kind of checks all these boxes at once, right? So we do the whole genome and transcriptome sequencing. We're able to provide clinical grade information back. It shouldn't be a replacement for routine CGP that I think should be offered through the government, but this is what we do. It's a real challenge though, because it depends on either grant money, donor money for philanthropy, for infrastructure, and that's not sustainable, right? And there are periods where we don't have enough, and we have to ramp down, and periods when we can ramp up. I think this is really important. This is how we move things forward over years and decades, but it's not the way to provide care, right? And I think as we've developed the evidence, it's time for the system to step in, right? Germline testing, inherited causes for cancer. This is a great example. This is before my time, but the group that I'm part of now developed all of this really strong evidence that in pancreas cancer, you should test for whether this cancer was inherited or not. And it took generating that evidence through research. Eventually it became convincing, where I think CGP is now, and the system took over, and now everybody with a diagnosis of pancreatic cancer should have inherited genetic testing, and that's funded in Ontario and in many jurisdictions around the world. I think we're at that point for CGP, and relying on it through research. Like, we do our best, but we're not a clinical grade lab. We're not like Alan's describing, in that we're looking to be able to provide smooth operations across the healthcare system. Like, to really have this equitable and accessible, we need the government to step up. I think they are in many ways. We're seeing a lot of increased access. I think CCRAN has been doing great work showing the evidence and the value to people of this. But I think we need to keep the momentum that we have, and research is part of it, but it's not the CGP through research is not the solution.
Thank you, Dr. Grant. Whether we wanted to or not, this has introduced the concept of resources and the economics involved in deploying comprehensive genetic testing. With that, I think it's a wonderful segue to Eddie Nason to tell us a little bit about his work about the economics of the economic benefits of comprehensive genetic profiling. Eddie.
Thanks, Jason. I appreciate being able to be here to talk about this. This is work that we have been doing in partnership with CRAN to really look at understanding why you might want to shift the system the way that Rob just identified. And why would the system take over? And one of the key factors in that has often been, well, can we afford to do it? And if we don't do it, what do we lose out by not doing it? And so what we wanted to do was to really do something that hadn't been done before in this area, which was to look at how would you try and understand what the cost difference might be from moving from a standard approach that we have right now to a universal access approach. And then if you did do that, modeling out for 5 cancers over 5 years, the 2025 to 2030 range, what would that look like in terms of both the costs associated with the system, but also the sorts of benefits you might see to patients? And that's patients broadly. We're not going into the realms of individual benefit, but we are thinking about this from a sort of generic system approach. And so by doing this, we did this modeling approach. We looked at these 5 cancers and really identified that there were going to be around 136,000 Canadians who are likely to get a de novo stage 4 diagnosis. These are newly identified stage 4 cancers. And for those people, if we shifted to a universal funding approach for CGP, what we actually saw was we were saving money in testing and treatment. So we had identified that there was the costs of doing single CGP tests, because of the way that they were being done, you were getting single information through a single test, was actually saving money compared to the sequential testing that would be required for the sorts of biomarkers that were identified in these 5 cancers. And so this was done with very solid evidence. It was looking at what was available through CGP testing at the moment, what data there was at the moment around what's actionable, what might create change, and what the treatments might be that are associated with that. And using that, we identified that if you shift over, you end up seeing anywhere between $700 and about $2,500 per patient of reduction in cost by using CGP instead of standardized testing approaches. So we're not just talking about the fact that it costs more and you get more. We're talking about the fact it actually costs less. So we've already got a reason now to think about this might be a good idea to shift to this as an appropriate approach, as a universal approach. When we looked at the benefit side of this, what we identified was, okay, well, what would it look like if we take some assumptions? There's good data in lung cancer right now around what the benefits are associated with using CGP over standard testing, sequential testing, in terms of the actual health outcomes associated with that. So we did an analysis looking at where are the actionable mutations, what are the actual benefits associated with that, what's the proportion of the population of those newly diagnosed cancer patients that would receive this benefit. And what we identified was that you're looking at actually a life year extension, so a life years saved of 3,440 over that 5-year, 6-year period from 2025 to 2030. And because I work with an economic research organization, we would be remiss if we didn't find a way to connect that to the sorts of things that relate to the economy as a whole. And so by using some of the standard metrics that are used in macroeconomics to identify what the value is of individual life in terms of when you are able to extend, we identified that actually you're also looking at $180 million in societal value that's being added back into society as well. So you're, at the end of the day, what you've got by shifting to this, our model suggests that you are saving money through doing testing. You're adding to people's lifespans, so you're actually saving lives. And then you're bringing money back into society as well. So we're looking at a situation where this looks pretty comprehensive and pretty convincing that this is a way to move forwards. I am a genomicist as my background in research. I did my MPhil in molecular genomics in Cambridge and used to work for Genome Canada. And I see all the connections between all of these things. And some of the things I want to talk about as well are the connections between these economic values and how you get to them. Because I think some of the things that Rob has been talking about and Alan talked about are really important in showing that this value is great, but the value is only there if you can find a way to unlock it. And in order to unlock it, there are certain things that you need to do. We need to make sure that we actually have the systems that can support this. We need to make sure that we are trusting the system players who are important in this, in pathologists, in oncologists, to really be able to support their patients and get to the access that they need. And as a couple of things that lean into what people have been saying is that one of the opportunities here is that there is a lot of shift now in Canada towards the idea of learning health systems and trying to build the idea that evidence and data as it's created is fed back into how you develop systems and make them run effectively and efficiently. And this is a fantastic opportunity to try and build some of the data that we get from these kind of CGP approaches back into the system to make this even more effective. All of this modeling was done on current data. As Rob mentioned, things are moving fast. We see new mutations being identified. We see new actionable mutations, new therapies. Over the next 5 years, from 2030 to 2035, this will be a bigger number. The number that you get back will actually increase because there will be more opportunities. There will be more availability of therapy. There will be greater number of potential actionable mutations to work with. So I think there are significant opportunities to make the shift now and then work out how we leverage that shift to really ensure we keep ramping up that benefit, keep seeing that going across to actually away from my, let's be honest, cold, hard economic figures and into Cynthia's idea of this is a real life thing. This is somebody's real life that changes because of it. So making that connection and making that shift.
Thank you, Reddy. That was a very helpful insight into some of the benefits, economic benefits associated with widespread implementation of CGP. Dr. Grant, I'm aware that you're under significant time pressure. we have a question from the audience that I think would be best addressed by you, and I know you have to leave. We heard Cynthia's story, where that started with advocating for access to CGP, followed by several liquid biopsies, and eventually whole genome sequencing. The question from the audience is, how often should CGP be conducted as part of patient care?
It's a great question. I think the truth is we don't know yet, right? And we're sort of just in the era where we're trying to get everybody to get it once. And for many cancer types, probably earlier in the journey is better, particularly at that diagnosis of recurrence or advanced disease. I think that's really the main message that I would hold here. As I alluded to, these tumors evolve. And in some circumstances, I think there's growing evidence that repeated genomic testing can be helpful. Now, one circumstance is if you're on a targeted therapy and there's well-described resistance mechanisms that would help us understand, should you continue or switch to another medicine that overcomes that? So yeah, lung cancer is a good example where there was clearly defined resistance mechanisms where new drugs would come in. And there are more kind of growing examples like that. The other category where I think it's quite important to consider is if there's any signal that the test you got wasn't fully reflective, right? So we haven't really talked about this yet, but this is a very technical thing. How much of the DNA that's sent represents the cancer? What's the quality of it? Like, there's many factors that can lead to technical challenges. And if you don't find any mutations, more often than not, that would be a technical reason, not a biological reason. And so if there's any signal between you and your provider that the CGP that you've had was inadequate, I think considering down the line, repeating this or trying another sample or a different strategy like liquid, I think these are the areas where we have the most evidence for repeated testing. But we don't know. There aren't a lot of studies of repeated testing, how many targetable alterations emerge through treatment pressures, like chemotherapy mutates cancer. So these are things that I think we'll learn more about and maybe can report back on that next year. But for now, those are the situations I'd recommend it.
Thank you, Dr. Grant. We're going to conclude today's discussion before we go to the questions on the concept around expanding access to advanced diagnostics and comprehensive genomic profiling. Dr. Mahoney, it's my understanding that BioCanRx has had discussions at the level of the federal government and other national stakeholders, such as the CDA. What are some of your ideas about expanding patient access, not only to precision treatments, advanced diagnostics, but also clinical trials?
Yes, so one of our mandates is really to advance these therapies to those with unmet needs. So we are continuously, and all of us within the BioCanRx ecosystem are continuously engaging with regulators, predominantly Health Canada, to think about how we bring access through innovative trials, through different models of access that might be non-traditional to what we normally see. I will say it's to be determined. I don't have two very actively doing, and we're spearheading on behalf of our patient community, on behalf of our scientists and clinicians in our network. So I hate to say, stay tuned for a more tangible response from me, but
Thank you, Dr. Mahoney. Dr. Spatz, you brought up a concept which I find totally fascinating. You opened your commentary by saying that it is important that we all work together to advocate for improvements to the healthcare system, specifically in this space, and you're representing laboratory medicine. CRAN and the Canadian Association of Pathologists share that opinion, and we do want to work together with Canadian patients and with administrators and clinicians such as yourself to advance this equitable access to these tests. How do you precisely suggest that the Canadian patient community work with leaders such as yourself, with organizations such as CRAN, with the Canadian Association of Pathologists to advance this specifically as you suggested?
Thank you very much, Jason. I think it's a very important question about advocacy in this field. I think we should do better, and we are lacking. Like if we take the UK model, which is probably the most successful model for population engagement in this field, we are lacking a kind of a super strong CIUK who would be able to bring all the actors you mentioned together. I think we need to create this organization. It's still very fragmented, although we are all moving to the same direction. And I think it's time to start having one umbrella organization, also bringing the payers and the regulators, certainly the CDA, but not only, also the provincial regulators, into this discussion. I think that everybody now want that. The farmers want that, and I think it's the right time. I just want to make two other comments. The first is we didn't discuss something very important in my view with an angle of pathologists that I'm sure you will share, which is the importance of prognostication, making the right decision for neoadjuvant, sometimes combination of neoadjuvant treatments, meaning treatments we will combine before anything else to make sure that we give the better chance to the patient. This is extremely costly. It's a very high burden for the society. We need to make sure that we are giving this type of approaches to the right subpopulation of patients. And CGP plays a very key role in this field, not only to identify targets, but really to make prognosis. And the second thing, and for me, it's an important message, I don't believe that CGP is the holy grail in the field of cancer biomarkers. I do not think that. I think that CGP is important, plays a role, and this has been illustrated by all the speakers today, but it has to be associated with other fields like proteomics, meaning proteins, pathology, morphology through the digital slides, and all together will allow us to shift to something that is new and much more powerful. And I think this is important also to realize that liquid biopsy, which is the next booming field in oncology, is not surrogated, predicted by comprehensive genomic profiling. And the conjugation of both is something that is very important to keep in mind.
Thank you. Thank you very kindly. Dr. Grant, since you're still here, we're going to pick on you one last time. You know, we had a summit in May held in Montreal. CRAN was a participant there. Again, this was focused on educating pathologists about new and incoming precision treatments, and Cancer Care Ontario was represented there. As a clinician providing care at Canada's largest cancer center, what's your perspective on what the provincial government is doing with regards to expanding access? You alluded to this earlier in some of your comments, that they've done a good job in helping move things forward. But how do you see the future moving specifically for care in Ontario?
It's a difficult question. I mean, I'm not heavily involved in politics. I mean, I try to focus on the science and the patients, and that's enough on my plate. You know, it's a tough. Eddie can probably get into it more, but how do we balance these expensive technologies, expensive medications as a society? I mean, my philosophical approach to this is, as in a public system, like we have a lot of opportunities, and Alan alluded to this, that I think we can learn a lot. Like we come together, just like in research, we can come together as a society to figure out, you know, where are these technologies best applied? How do we apply them? And that may lead to cost savings, like what Eddie explained. So I think being this learning health system idea that's been raised a couple times here, I think it's very powerful. And as a shared resource, our healthcare system, I think that we're in a unique position to try and be leaders in this. So I'd love to see more on this. And I think CGP is something we should be pushing for. I think it's a very concrete, and great to hear the economic data. This is something that I think is something we should be advocating and pushing forward.
Thank you, Dr. Grant. Cynthia, you've heard from some of the panelists here, and as a patient who's gone through this process and who has paid out of pocket and advocated for yourself, I was hoping to get some of your thoughts on some of what the speakers have presented here today.
Well, there we go. Yeah, I think I'd just like to start by thanking everyone on the panel today. For your work in advancing cancer care, research and care. I have so much to say. I typically do anyway, but reflecting on the discussion, I think it's clear that we have so many steps ahead of us in terms of improving access to CGP and the related therapeutics. These advancements, they offer a beacon of hope to patients, but we need to ensure that all patients can benefit from these innovations. I do want to also thank Dr. Grant and his colleagues at Princess Margaret Cancer Center and University Health Network, specifically for their efforts surrounding biliary tract cancers, particularly with that focus on precision medicine. Their work is vital, and as we've mentioned in this discussion today, I think it highlights the pressing need that we have to establish more sustainable sources of funding for ongoing care. I think as we move forward to a future that is defined by personalized medicine, that patients increasingly view CGP and treatment as integral components of their care. So we have to advocate for access to timely access, but also timely test results and to the treatments. And every patient deserves equitable access to funded therapies. So whether that comes, and just to echo Dr. Mahoney, like that might come through the expansion of pan-clinical or pan-tumor clinical trials, or maybe it's even broadening the indications for drugs that are currently approved for other disease sites. I truly believe that universal healthcare should encompass both testing and treatment as fundamental rights. I'm really excited about the findings that Eddie spoke of in the report. I think that we have a lot of ground to stand on with that evidence. For early age onset cancer patients, the reality is often so stark. Many of us are diagnosed with advanced cancer, aggressive cancer, and we are acutely aware of the urgency to access information that helps us manage our care. The need for CGP is not just this matter of preference anymore. We really do see it as a matter of survival and hope. And I would encourage all patients and caregivers to connect with patient advocacy and support groups so that you have a very good understanding of CGP, the role it might play in your care, and also how to access it. Because it is our hope. At present, this is our big hope. It can provide insights into possible ways of radically changing our treatment. And we need to make sure that everyone can access it, regardless of the tumor type, geographical location, socioeconomic status. These are vital tests that we need to access, and we also need to access the subsequent treatments. So just to wrap up, I guess looking ahead, I think we have to continue for improved access. We have to push for these systemic changes that prioritize patient care and ensure that everyone has access to precision medicine. I think that our future does include comprehensive testing and effective treatments that are universally accessible. And that gives patients the care that they deserve and ultimately, the hope that they so desperately need.
Thank you, Cynthia. I would invite all of our listeners to put any questions you may have in the chat box, and we'll address them to our panelists. And actually, Cynthia, the first question is for you. So you have described your own advocacy to obtain comprehensive genetic testing fairly early in your journey. The question from the listeners are, what did you do specifically in terms of how did you advocate for yourself and ultimately achieve the results you were looking for?
Well, I think it was early. It was in 2022 that that my disease became metastatic, and that's the point at which we felt that there were very few options. So there wasn't a lot of conversation surrounding CGP in Canada, but I had connected with what's called the Cholangiocarcinoma Foundation in the US. It's an international program. And that's where I first heard of it. So that's when I started having conversations with my local team about what role CGP might play in my care. And to be honest, they didn't feel that it would play any role in my care. So there was a lot of me pushing for access to just simply try it. So I think, to answer that question more specifically, I think the earlier that you can have a conversation about CGP, especially with metastatic cancer, the better. And I'm not always really great at taking no for an answer the first time, and I encourage others to do the same. I think that you can have open conversations with your care team, and sometimes you learn why that something won't happen, and other times you end up coming to a place where you both agree that it should happen.
Thank you, Cynthia. Eddie, the next question is for you. So one of the listeners thought that what you presented was incredibly compelling. But their question to you is, how do we take this data that you suggest that there's economic benefit to moving to CGP? What do we do to move forward here? So you've got a number. What do you do with that number to improve care?
It's an excellent question. And then really, I think it speaks to Alan's comments earlier about the fact that we all need to work together on this. This is a compelling case, but it's only a compelling case if lots of people point out how compelling it is. And so the ability to have different parts of the system, my side is we are the dispassionate evidence side, but also with the patient advocacy side, with the physician side, with the pathology side, with the policy making side, even with the health technology assessment side, who previously probably would not have wanted to dabble in this. There is a lot of opportunity for people to have these conversations collectively and to move from the idea that this is what we could get to what are the concrete steps we take in order to get to it. And so we identify a few things in our report around the fact that, what we'll need to do around making sure that we keep the alignment between testing and treatments, making sure that we are bringing the pathology and the clinical team into the decision making over what's the most appropriate test to use within this CGP funding environment. Trying to make sure that we align the existing infrastructure needed for genomic testing within different provinces with the ability to utilize it for patients themselves. And so there are a number of different moving parts that I think are perhaps all the wind is blowing in the right direction for all of them. And the more that we can streamline it by coming together and utilizing things like these numbers, like the capacity, the human story that actually underlies this, the more likely we are to create shifts in the system.
Thank you, Eddie. Dr. Spatz, we have two extremely technical questions for you. The first is, as Canada, and we'll use Quebec as an example, has expanded access to genetic testing, how have you managed to ensure that the quality standards in the lab were established and adhered to as you rapidly adopted these new testing modalities?
Simple, we have not. We have not, and an extremely interesting question and ongoing challenge. We have now data showing that the prevalence, meaning the frequency of the found alterations, varies across lab across the country, even within sometimes in the same provinces. So this aspect is crucial, and I believe is now urgent need. It's interesting because actually I opened this conversation with Quebec Ministry about that, precisely to be in a situation where we could do a retroactive quality assessment of what is being done in this field.
And following on that, another very precise question from the audience. What does this cost overall for patient? What does a panel test roughly cost in terms of patient care?
Zero. We are in a social environment, social health environment. So this is taken care of by the state. I think that what AD has mentioned about the benefit of CGP needs to be carefully assessed based on the comparator that was used in this study. This is the type of conversation, very technical actually, that we need to have all together at the country level.
Thank you, Dr. Spatz. Dr. Grant, one other question from the audience. In your practice experience, specifically in terms of early age onset cancer patients, how have you found that comprehensive genetic testing has affected these patients' outcomes and long-term quality of life?
Yeah, it's a great question. I mean, for early onset, not all targetable alterations, but many are enriched in younger people. So I think the potential yield of this test is higher for younger individuals, particularly exceptionally young, like cancers that typically present in their 70s, like pancreas cancer. If you're a 30-year-old, something must be different. So I think the importance is even higher in younger individuals. The other piece, and I think it's really important that we distinguish inherited genetic testing from somatic genetic testing, right? These are two related but distinct concepts. The importance of inherited genetic testing is particularly important for unusually young cancers, and often that can lead to targeted treatments similar to the tumors. So I think it's important across the board, but particularly important in early onset, and that's why we're talking here today.
Thank you, Dr. Grant. Thank you to all of our panelists for your time here today. Eddie, Dr. Spatz, at some point in the future, I hope we can expand on your discussion around the economic value behind a platform for sharing the data that's being generated from comprehensive genetic testing. And I think there's actually a concrete impact to patient care. And hopefully that there's a number Eddie can put on that in terms of the economic value it'll generate for the country as further support for expanding access to this testing. I thank you all again. Cynthia, thank you for sharing your story. And I'll pass it back to Cassandra.
Thank you so much, Jason. There was a question earlier about what's being done in terms of moving this forward from a policy perspective. And I will share that CRAN is leading a national biomarker advocacy campaign in collaboration with a number of our patient partners. And we will be bringing the evidence generated by Eddie and team at the conference board to policymakers, along with our publication that came out of that will be coming out of the biomarkers conference held earlier this year. And we will be, advocating tirelessly. We will be educating and bringing that level of awareness to policymakers. CRAN as well will be further engaging with the conference board to continue to generate more economic evidence to continue to drive this forward. So biomarker testing, comprehensive genomic profiling is certainly a topic that we at CRAN are very passionate about. For our viewers that have enjoyed this awesome discussion and want to learn more, please save the date for our Biomarkers Conference next year, which will be June 18th and 19th. And we dedicate 2 full days of discussion to biomarkers at that event. So more information certainly to come. But thank you very much to all of our panelists. And Cynthia, thank you so much for very vulnerably sharing your story as well. And now we're heading into our next health break. So as we do so, we'll be sharing a video presentation about multi-target prospective screening study for early detection of colorectal cancer. We are back live at 3:30 p.m. Eastern Time, and that is with our clinician roundtable discussion on advancements in the management of lung cancer. We'll see you then.
Thank you very much. Bye-bye.
Thank you.
Thank you.